Welcome to the deep dive. Today we're tackling something incredibly familiar for, well, probably most people listening, the tension type headache, or TTH.
That's right. That sort of dull, pressing ache maybe feels like a band around your head.
Yeah.
Super common.
Exactly. And our mission today is to really pull out the key info about TTH from these revision notes we've got.
Yeah.
We want to make it clear, memorable, really high yield stuff, whether you're actually revising or just curious.
Yep. Cutting through the noise, focusing what you really need to know. We'll cover what it is, what might cause it, risk factors, how it actually works biologically.
What else it could be mistaken for, who gets it, the symptoms, diagnosis, treatment, the whole lot.
Basically everything from definition to prognosis and potential issues, all based on these notes. Let's dive in.
Okay, let's start right at the beginning. What is a tension type headache? What defines it?
So fundamentally, it's a primary headache. That means the headache is the main problem, not a symptom of something else underlying it.
Right.
And the pain itself is typically dull, sort of aching, not that throbbing you might get with a migraine. A really key feature is that it's usually bilateral.
Bilateral, meaning both sides of the head.
Exactly, both sides. People often describe it, like you said, as that tight band feeling or pressure, like something squeezing their head.
Got it. Now, the notes mention specific criteria, especially for diagnosing it in children. Can you break that down a bit? It sounds quite specific.
Yeah, it is quite structured, which is helpful for diagnosis.
Hmm.
For kids, they need to have had at least 10 previous headache episodes that fit the bill.
10 episodes, okay.
And each of those headaches needs to last somewhere between 30 minutes and, believe it or not, up to 7 days.
Wow, 7 days is a long time for a headache.
It can be, yeah, though often they're shorter. Then the pain needs to have at least 2 of these characteristics. It's a pressing or tightening feeling, not pulsating. It's mild to moderate intensity.
Meaning it doesn't completely stop them in their tracks?
Right, they can usually still function, maybe not comfortably, but they can carry on.
Yeah.
It's located on both sides, bilaterally. And importantly, it doesn't get worse with routine physical activity, like walking or climbing stairs.
Okay. And what about other symptoms?
Crucially, there should be no nausea or vomiting. And for sensitivity to light and sound, photophobia and phonophobia, either they're completely absent or only one of them is present, not both.
Ah, so that helps distinguish it from migraine, which often has both, plus nausea.
Precisely. It's like a diagnostic checklist based on the history.
That's really clear. The notes also talk about episodic versus chronic TTH. What's the difference there, and why is it important?
That's a really key distinction. Episodic TTH means the headaches happen on fewer than 15 days per month.
Okay, less than half the month.
Yeah. Chronic TTA, on the other hand, is defined as having these headaches on 15 or more days per month, often for several months.
That sounds much more debilitating.
It absolutely can be. And the notes highlight something important here. Chronic TTH is often linked with medication overuse, taking pain relief too often, and also with depression.
Right, so getting the diagnosis right, episodic versus chronic, really impacts how you manage it.
Definitely. The treatment approach can be quite different.
And there's a mention, too, about potential overdiagnosis or maybe missing a migraine.
Yes, that's a really important point. Because TTH is so common, sometimes headaches with some migrainous features might get labeled as TTH.
And why is that a problem?
Well, migraines often need specific treatments, like triptans, that don't usually work for TTH. So if someone's actually having migraines but being treated for TT, they might not get effective relief. You've got to look out for those migraine features, the throbbing, the nausea, the significant light and sound sensitivity.
Okay, good point. So we know what it is, but what actually causes these headaches? What's the etiology?
Well, the frustrating answer is that the exact cause isn't fully understood. It's thought to be a combination of things.
Like what?
Genetic factors seem to play a role. It might run in families. And environmental factors are definitely involved. But the notes really highlight muscle tension, especially in the head and neck region.
Yeah, that makes intuitive sense.
Right. And stress is a huge trigger or a contributing factor for many people. There's also mention of potential dysfunction within the central nervous system itself, how the brain processes pain.
So it's not just tight muscles, it might be how the brain is interpreting signals, too.
Exactly. It seems to be more complex than just peripheral muscle tightness. The way the central nervous system modulates pain could be altered.
It's interesting. And who tends to get these headaches more? Are there specific risk factors?
Yes, the notes list a few key ones. Having a family history of TTH is one. High levels of stress, anxiety, or depression are also strongly linked.
That fits with the stress trigger idea.
Absolutely. And lifestyle factors come into it too. Things like poor posture, think about hunching over a desk all day, and a lack of physical activity are also mentioned as contributing factors.
Makes sense if you're tense and not moving much.
Yeah.
So let's dig a bit deeper into the biology. What's the pathophysiology? How do they actually happen?
Okay, so it seems to involve a couple of key things. One is increased pain sensitivity, what we call pericranial tenderness. Basically, the muscles around the head and neck are more tender and sensitive to touch.
Right.
And there's that heightened muscle tension we talked about. But importantly, the notes also point towards central mechanisms. This means changes in how the brain and spinal cord process pain signals.
Like the pain volume dial is turned up a bit.
That's a good analogy, yeah.
Yeah.
There might be an issue with the pain modulation pathways.
Mhm.
And neurotransmitter imbalances, the chemical messengers in the brain could also be involved. So it's a mix of peripheral factors like muscle tension and central nervous system changes.
Fascinating. It's more complex than you might first think. Okay, so if someone presents with these symptoms, what else does a doctor need to consider? What's on the differential diagnosis list?
This is really crucial for safety. While TTH is common and usually benign, you have to rule out other possibilities. Migraine is probably the most common differential.
We've touched on that distinction already. What else?
More serious things need consideration, although they're much rarer. Things like giant cell arteritis or temporal arteritis, that's inflammation of arteries, often in the temples, usually in older adults.
Okay.
Then there's the really serious stuff, like a subarachnoid hemorrhage bleeding around the brain, typically causing a sudden, severe thunderclap headache.
Definitely need to rule that out.
Absolutely. Other possibilities include trigeminal neuralgia, which causes sharp facial pain, TMJ dysfunction problems with the jaw joint, sinusitis.
Sinus headaches. People talk about those.
Yeah, though true sinus headaches related to infection are less common than people think. Also, encephalitis, brain inflammation, cervical spondylosis, neck arthritis potentially causing referred pain, and even carbon monoxide poisoning need to be kept in mind in the right context.
That's quite a list. Really highlights why getting checked out is important if a headache is unusual or severe.
Exactly. Don't just assume it's TTH if there are worrying features.
Right. Now, how common are these tension-type headaches? What's the epidemiology look like, say, in the UK?
Oh, they are extremely common. The notes state it's a highly prevalent primary headache disorder. The lifetime prevalence, meaning the proportion of people who experience it at some point in their lives, is estimated somewhere between 30% and a whopping 78%.
Wow, up to nearly 8 out of 10 people.
Yeah, it's huge. The incidence rate, so new cases per year, is around 14 to 44 per 1,000 people.
And is there a typical age?
It usually starts between 20 and 30 years old, and it seems to peak in the 20 to 39 age group. And the notes also mention it's slightly more common in females than males.
Okay, so very widespread, especially in young to middle-aged adults. Let's talk about the experience itself. What are the classic symptoms and signs?
Okay, symptoms. The pain is typically mild to moderate. Usually it's bilateral or feels generalized all over.
At the quality.
It's that pressure, tightness, fullness, squeezing sensation. Some people say it feels like wearing a tight cap or band. Location-wise, it's often at the back of the head and neck, the Occipital nucleolino area, or across the forehead, the bifrontal region.
What else might someone notice?
They might feel actual muscular tightness or stiffness in their neck, scalp, or forehead. Difficulty concentrating can happen, and sometimes symptoms of stress or anxiety, maybe trouble sleeping.
And crucially, what's usually absent.
Right. Usually no significant photophobia or phonophobia, or only one is present. Typically no nausea or vomiting, no warning signs or aura beforehand, and simple pain relief often helps. People can usually still manage their normal activities even if they don't feel great.
They feel well between attacks, too.
Generally, yes, though they might understandably develop some anxiety about when the next headache will strike.
Okay. And what about signs a doctor might find on examination?
Often, the physical exam is completely normal. That's actually reassuring, helps rule out other causes. But sometimes, the doctor might find tenderness when pressing on the scalp or the muscles in the upper neck, the cervical muscles.
So the exam is mostly about ruling things out.
Exactly. A good head and neck exam is important, checking blood pressure, looking at the optic fundi at the back of the eye, all to exclude other potential causes. The key is that TTH is often described as featureless. It lacks the specific neurological signs you might see with other headache types.
Right. And the notes mention a mnemonic.
Ah, yes. A potentially useful one is BLT-NOT, bilateral generalized, less severe than migraine, tightening quality, not aggravated by routine activity, and occipital frontal location. It sums up some key features.
BLT-NOT.
Yep.
I like it. Okay, so diagnosis relies heavily on the patient's story and a normal exam. What about investigations? Are scans or blood tests needed?
Generally, no. The notes are very clear. Diagnosis is primarily clinical, based on the history and physical exam.
So no routine MRI or CT.
Nope. Brain imaging and lab tests are usually unnecessary unless there are atypical features or specific red flags suggesting something else might be going on.
What are red flags, quickly?
Things like a sudden, severe onset, worsening headache pattern, neurological symptoms like weakness or numbness, fever, neck stiffness, headache starting after age 50, or in someone with a history of cancer or HIV.
Got it. So in a typical case, no scans. The notes also say cervical spine x-rays or eye tests are unlikely to help.
That's right. For a standard tension-type headache presentation, those tests aren't typically useful for diagnosis.
Good to know. Avoids unnecessary investigations. Okay, let's move on to management. How are these headaches treated?
There's a sort of two-pronged approach, non-drug strategies and medications.
Let's start with the non-drug options.
Okay. A big part is reassurance. Giving a positive diagnosis and explaining what TTH is can relieve a lot of anxiety. Addressing underlying stress, anxiety, or depression is really key.
Makes sense, given the link.
Absolutely. Lifestyle advice is important too, things like regular exercise, which is shown to be beneficial, and improving posture. Physiotherapy might be helpful, especially if neck issues seem to be contributing.
What about things to avoid?
Definitely avoid opioids and codeine-containing painkillers. The notes are quite firm on this due to the risk of addiction and medication overuse headache.
We'll come back to that. Anything else on the non-drug front?
Promoting general healthy lifestyle changes, maybe exploring things like cognitive behavioral therapy, CBT, for stress management. Some people find acupuncture or osteopathy helpful, though evidence varies. And as we said, avoid neuroimaging just for reassurance in typical cases. Explanation and discussion are key.
Okay, so lots of focus on lifestyle, stress, and reassurance. What about medications? When do they come in?
Medications are mainly used for acute relief of episodic TPH, or sometimes for prevention in chronic or very frequent episodic cases.
So for the occasional headache.
Exactly. For episodic TTH, happening less than, say, a couple of days a week, simple over-the-counter analgesics are the first step. Ibuprofen 400 milligram is often recommended first line.
And if you can't take ibuprofen,
Alternatives include other NSAIDs like naproxen or ketoprofen or paracetamol. Aspirin is also an option for those over 16.
but there's a big warning about using these too much, right? Especially for chronic TTH.
Huge warning. Overusing simple analgesics, especially if you're taking them more than 10 or 15 days a month, can lead to medication overuse headache, making the problem worse. So for chronic TTH, these should be used very sparingly, if at all, for acute pain.
Is there anything else for acute attacks?
The notes mention potentially considering a short rescue course of naproxen, maybe twice daily for up to 3 weeks, to try and break a cycle of frequent headaches, but that would be under medical guidance.
Okay. What about preventing headaches if they're happening really often or chronically?
That's where preventative medications come in, usually considered for chronic TTH or very frequent episodic TTH. The main option recommended in the notes is a low dose of a tricyclic antidepressant, most commonly amitriptyline.
An antidepressant for headache.
Yes, it's used for its pain-modulating effects, not primarily for depression in this context, although it can help if depression is also present. You start at a very low dose, maybe 10 or 15 milligrams at night, and increase it gradually.
How long would someone take that for?
If it works well, maybe for 4 to 6 months after improvement, then you'd try to gradually withdraw it. Nortriptyline is mentioned as an alternative tricyclic that might have fewer side effects for some people.
Are other types of antidepressants used, like SSRIs?
The notes specifically advise against using SSRIs for chronic TTH prevention.
Okay. Any other preventative options mentioned?
Anxiolytics like beta blockers aren't generally recommended, partly due to potential depressant effects. And benzodiazepines like diazepam should be avoided because they're addictive. And again, a strong caution against codeine and dihydrocodeine in chronic TTH.
Got it. Seems like amitriptyline is the main preventative medication option discussed here.
Based on these notes, yes. It's worth mentioning that while NICE guidelines for migraine prevention were updated recently, the specific guidance for tension headache management hasn't had major changes noted here.
Okay, so we have management strategies. What's the general outlook for people with TTH? What's the prognosis?
Generally, it's pretty good. Episodic TT, while common, usually responds well to simple measures and doesn't tend to interfere hugely with life.
And chronic TTH?
That can be more challenging, as you'd expect, It might require ongoing management and can certainly have a bigger impact on quality of life and lead to more morbidity or disability if it's not well controlled.
Right. Are there any direct complications from TTH itself?
Tension-type headaches themselves don't usually cause serious physical complications. The main issues arise from the impact of chronic pain on daily life, work, and mood.
And the complication from treatment?
The big one, as we've stressed, is medication overuse headache from taking pain relief too frequently. That's probably the most significant potential complication to actively avoid.
Okay, we've definitely covered a lot. So just to quickly recap, tension-type headaches, super common, that tight band or pressure feeling, usually on both sides, mild to moderate pain, generally without the nausea or severe sensitivities of migraine.
Yep. And diagnosis is mainly based on that typical story and ruling out other causes. Management involves lifestyle, stress reduction, physiotherapy potentially, and then simple analgesics used sparingly for episodic attacks.
And preventative meds like amitriptyline, considered for chronic or very frequent cases, while carefully avoiding medication overuse.
Exactly. It seems straightforward, but there's that interesting mix of muscle tension, central pain processing, and psychological factors all potentially playing a role.
So, thinking about all this, perhaps you listening can reflect on any headaches you experience. Does this description resonate? Do any of the management ideas seem relevant? Of course, this is for understanding. Always chat with a doctor or healthcare professional for a proper diagnosis and treatment plan if you're concerned.
That's a great point. Thinking about how you describe your headache using some of these terms like bilateral, pressing, non-pulsating could actually help you have a more productive conversation with a doctor.
Absolutely. And if you are studying for medical exams or just want to explore topics like this further, do check out passthemsra.com.
And freemsra.com as well. Both are excellent resources for learning and revision.
Definitely worth a look. Well, thanks for joining us on this deep dive into tension-type headaches.
Thanks for listening. Until next time.